Thank you so much. It's an honor to present you, Dr. David Wright. He's a family medicine specialist in Austin. He graduated with honors from the University of Texas Medical Branch at Galveston in 1980. He has more than 40 years of diverse experience, especially in family medicine, and actually 41 years in Austin, in addition to the other years prior to that. Sorry about that. He was affiliated for many, many years with the UT Southwestern Residency Program, and currently is affiliated with the Dell Seton Medical School at UT. He works with many doctors, specialists, and medical groups, and with the Moody Medical Center operated by Vivint Health. And he's phenomenal. If you don't know that, there are a lot of us in here who can attest to that. How many of you in here have worked with Dr. Wright over the years? You work in Austin. I suspected that most of you had. I think we met in 1987, 86, 87. So, and we worked together on many, many projects. Again, he's a family medicine physician in Austin for over 40 years. He still continues to work with the graduate medical programs, and he's won numerous teaching awards. He's been honored as the Texas Family Physician of the Year by the Texas Academy of Family Medicine, and he just continues to serve our community. Welcome, Dr. Wright.
Thank you. Okay. All right. So I think you can hear it, right? Very good. So this is good. I'm going to move it up. Move it up. Move it up. Go ahead. See if that works better. All right. I think we're ready to go. We're back in business. Yes. Here? All right. Very good. Very good. Well, it's nice to see people. It's been a long time. You know, this has been kind of a strange period of time, I think, for all of us with going through COVID. I think this is hopefully what I'm going to talk about today will kind of bring a little hope and excitement to what might be coming. And so that's what the top the message here is, where we've been and where we're going. So it's I think ties into what this conference is trying to accomplish, which is basically a look back and to look forward. So that's what we're going to do over the next 30, 40 minutes. So let me make sure. All right. So these are the kind of objectives. These are sort of the outlines of what we're going to talk about. And to look a little bit at sort of looking back and looking forward is the evolution of HIV treatment, kind of where we've come over the last 35 years. What I'd like to talk also a little bit about is sort of the barriers that continue to exist. I think you can think of these as barriers to adherence to HIV treatment. You can look at it as social determinants of health, health inequities. This is a significant problem, I think, in trying to make people that are HIV infected, allow them to be successful with their treatments. And because what I'm going to talk about is that it's the initial treatment that is eventually going to, I think, put people in line for the ultimate goal for all of this, is how we're going to cure HIV. We're going to talk a little bit about what's the Achilles heel of people that are HIV infected, and that's what's referred to here as the HIV reservoir sites. What you have to think about is that this is a virus that infects cells And not only does it replicate itself, but it also then buries itself into its host's genetic material. And so when it's in there, then it has the potential to continue to be able to immortalize itself and continue to replicate itself. And so looking at where these hiding places are, where the reservoirs are at, and how to eliminate that, that's sort of the linchpin on how we're going to move forward and eventually get to a cure. And it's like anything else in life, you gotta have sort of kind of a roadmap. You have to have a template or something to think about. And that's what the fourth bullet point about is that we have that right now. And that's a subset of HIV-infected individuals that are called the elite controllers. And elite controllers are people that have been recognized for 20 plus years. These are individuals that test positive for HIV. When you started to look for the virus and measure a viral load, it's very difficult to find virus. I mean, it's there, but in very, very low levels. It's become a little bit easier to find these very low levels with now that the PCR technology has gone all the way down to 20 copies. There are people that on good days have less than 20 copies, on a bad day maybe they have 100 copies. But the thing that they have in common with elite controllers is that these are patients that are able to control their replication but don't take medicine. The question is, how did that happen? What can we learn from this subgroup of patients? And there's going to sort of, and what we're learning is that there are the sort of template. They're sort of the roadmap of how we may be able to lead other patients into a cure. And then we're going to touch briefly about what potentially is available, and what are these sort of cure strategies going to look like, and what are sort of the different options that patients may have. And it's here. I mean, we're right here in Austin in 2022. There'll be a number of clinical trials that will begin to sort of lay the groundwork of what is the strategy going to look like for patients that may be able to get or be appropriate to attempt to cure their infections. Okay. Now, so if you look at sort of the evolving treatment, and I put this here because it sort of reminds me a lot of sort of how things were so dismal not that long ago, and how things are sort of going to be able to get so much better. So if you look at sort of what's happened here, you've had this tremendous change in evolution in a very short period of time. So if you look at that, and up here the first bullet point is that 1983 HIV was discovered. And that's probably a misnomer, in that it was just HIV was recognized. It had probably been here, and we know it's been here for a much longer period of time. But 1983 is a sort of a watershed year, because that's the year that a young physician at UCLA, Michael Gottlieb, happened to have a collection of patients that he found intriguing. They were young men dying from pneumocystis. And one thing led to another, and he wrote a letter that was published in the Morbidity Mortality Weekly of the CDC. And so that he reported what his observation was on the wards at UCLA. And this very interesting thing happened. The following week, and the week after that, and the week after that, other physicians across the country wrote in letters and said, I have a couple of these patients that are just like this. And so that led to sort of the realization something was happening. Whatever was happening was not good. And so very quickly after that, the NIH, Dr. Robert Gallo, was able to sort of piece kind of pieces of the puzzle together and realize that this was a virus that is unique in the sense that normally most viruses and bacteria go from DNA makes RNA, and RNA makes protein. That's sort of the pivotal statement of molecular biology. So how was it then, this virus that had no DNA, how was it able to replicate itself? It only had RNA. So what was found in is that the RNA makes the DNA. It went backwards. So that was called a retrovirus. And the key step was an enzyme called reverse transcriptase. So that then people were able to say, there's a virus out there using reverse transcriptase. Are there any drugs that might inhibit reverse transcriptase? So they put it into a database at the National Cancer Institute because there was always an interest about viruses and cancer. And they found that there was one particular drug, AZT, zidovudine, that had an effect against reverse transcriptase. And so that then, very quickly, that drug was taken off the shelf, started to manufacture, and then led to a treatment, which is there, as you can see, in 1987. Now, the drug was not considered like treatment. It was sort of like something that could buy time. So the idea is that you would start somebody who was very, very sick on AZT, and it might extend their life for 3 to 6 months. So it was a way to kind of tread water. And it really wasn't until 1995 where you see you have now more than one drug. You have another drug called 3-TZ, which you could put together, and then you could actually have treatment. Treatment was pretty good for about maybe 6 months. And then what happened is that you, in a short period of time, started to see the virus became resistant to these medicines. So the watershed year then is really then 1996, when now you had other drugs that came available. You now had a class of drugs called non-nucleoside reverse transcriptase, protease inhibitors, and so now you had triple therapy. And they're at a very big conference, an AIDS conference. Dr. David Ho was asked the question, well, what do you do about HIV? And he said, well, you got to give medicine. It's all about the virus, dummy. And so the idea was the more drugs you had, the more likely you could suppress viral replication. And that's was then, the limitation there was that many people in this room realized it was a handful of pills, 2 or 3 times a day. So in 2006, everything got boiled down to 1 pill once a day, using a drug called the tripla. And we don't use that drug much anymore because in 2012, things got better. We got safer drugs, more effective drugs, and that led to the use of a drug called integrase. Integrase takes this one step further after the virus has replicated itself, and to get into your genetic material, it has to use an enzyme called integrase. So now you had a set of drugs that block that particular step. The amazing thing here is that those drugs sort of just stopped viral replication dead in the water very, very quickly. The other drugs, it took a period of weeks, sometimes months, to be able to suppress viral replication. Integrase compounds were able to do it in a very short period of time, 2, 4, 6 weeks, depending on the type of integrase compound. And so that then changed sort of the landscape, because now we were able to sort of intervene very quickly with medicines that would suppress viral replication almost immediately. So you didn't have to really worry that much about collecting all your data points before you started somebody on a treatment regimen. You could just start them on what we call rapid initiation. Patient came in on a Monday, tested positive, and from an outreach program at the Kind Clinic, and then the next day they came to clinic and they started on medication. This was like kind of unheard of. So we were able to get patients that test positive and get them undetectable in a period of about 3 weeks. Now, why was that important? And we didn't recognize really why that was important when we were doing it, which is that probably good to do. But what we have come to realize is that if you can find somebody that has just recently been infected, you get them on treatment and make them undetectable, you're going to change probably the whole sort of their journey with HIV. Because what we're finding is that if you can take somebody acutely infected, stop their viral replication quickly, then you're going to eliminate or minimize the reservoir sites, and you're going to preserve much more of their immune function. It's more likely that they're going to sort of begin to mimic these elite controllers. Now, the other thing about 2012, which was pretty exciting, was the fact that not only at that time were we having better medications, but we also had a new strategy, which was how can you prevent HIV infection, other than, say, safe sex. And so at this period of time, the concept of pre-exposure prophylaxis came about. Now, what was important about that was that you could give people at risk an option to reduce their risk without necessarily radically changing their lifestyle and behavior. It was basically as if you protect yourself, minimize your risk factors, reduce your unprotected sexual encounters, and take this medicine, you have a very high likelihood that you're not going to become HIV infected. But the most important thing about that was not necessarily PrEP as a way to prevent. It was more of a way to get people into medical care. They're coming, as part of PrEP, if you're on this medication, you're going to come into clinic and be tested every 3 to 4 months. Make sure you're going to get STI checking, you're going to get an HIV test. So it allows us then the opportunity to get people screened, and if they test positive, to get into care rapidly. And that is, I think, is one of the sort of hallmarks of what PrEP programs are about. And then that sort of leads into where we're at right now in 2021. And now we're on the beginning of what a thought process and a discussion of what can we do and what is a cure strategy going to look like. The other thing that reminds me is that in 1996, I had a number of patients, and it was basically just telling them things are getting better, the drugs are getting better, and you're going to get much better, you're going to get healthier. And at the same time, it was very interesting over that period of time. I'd already sort of kind of grew older with my patients, in the sense that, and for 1983, 84, I was in my early 30s, and I was taking care of all these patients that looked just like me. They were my same age group. And so we kind of, those that were able to survive, we kind of grew older together. But in 1986, I realized there's still all these young people that are getting infected. And they were sort of kind of down, feeling bad about all of this. But I told them was that the medicines are getting better. So I'm an older guy, but you're young, and I can guarantee you are gonna, if you take your medicine and stay healthy, you're gonna live long enough that you're gonna see the cure. I said, I probably won't be around to see the cure, but you're gonna be around to see the cure, and you're gonna have a potential to be cured. So it's very sort of endearing to me that here we are in 2021, on wood, I'm not dead, and I'm still seeing patients, and I'm here to see this cure sort of happen. Now, one of the things that I think we need to look at here is that part of the strategy of getting to the cure is that you gotta kind of stay alive, and the way you stay alive is you take your medicine. And this whole issue about barriers to adherence really has evolved involves social determinants of health. How do you allow people to be in the clinics, come to the clinics, get care, stay on their medicines, and do all the things that will eventually keep them alive long enough so that they can have an opportunity to participate in a cure trial? Is that these are all, I think, a list of things that patients face every day. Difficult life conditions, unstable living conditions. In the clinics where I work at the Kind Clinic and at the Vivint Clinic, probably the most important people in our clinic are the housing case managers. It's the biggest problem. They keep people's hope alive and to be able to allow them to kind of be successful. I think a lot of people in this group here are very well of the whole concept of housing first. Before you can do anything else for people that are homeless, to make their life stabilized, you got to give them housing. And it's the same thing for patients that are facing a chronic medical condition like HIV, is that you have to get them in a stable housing. Part of the problems I realize in this state is sort of this whole thing about systems barriers. When you have a state that's not willing to make the commitment that you're going to give healthcare, make healthcare more accessible for people, that you can't afford to do Medicaid for all the people that would need it. I think that's not a very smart move. And so these systems barriers, and all the other things that patients are faced with, they don't have a phone, they don't have an insurance. I've been amazed by the number of patients that I can't talk to or get in contact with because they don't have a phone. They either got stolen, lost, or they couldn't pay the bill anymore. Patients don't have insurance. The number of patients that don't have IDs, it's like you can't have entry into anything if you don't have an ID. Barriers, things with ADAP, transportation. One of the biggest problems that if you look at the clinic system, it'd be community care, Kind Clinic, or Vivint, is that one of the biggest obstacles is the fact that patients can't get to their appointments. And we have, high no-show rates of maybe 15, 20%, 25% at times, but the biggest problem is patients couldn't get to the clinic. Buses don't run, they don't run on time, there's this, that, and the other. So there are all these things. And then when you throw on top of that the whole issue with alcohol and drugs, psychiatric issues, this is sort of a tough time of the year, in that holiday season is always very impactful in regards to creating anxiety, depression, bringing up kind of tearful memories. Sometimes memories are good, but sometimes it's very stressful. So you see a lot of issues of depression at this time of the year. You see a higher incidence of suicides at this time of the year. If you have private insurance and you turn to the back of your insurance card, you call a 1-800 number saying, I need help. You need to talk to somebody about this. Yeah, you might get somebody to get you into an office in 3 or 4 weeks. So just imagine if you're having psychiatric issues, you don't have no insurance, you don't have any cards, you don't have any ID, how are you going to interface with psychiatric help? So all of these things impact things significantly on people being successful. And in my situation, if I want somebody to be successful so that they can have an opportunity to think about cure, you got to be adherent to their medicines. That's the first thing. Because if you're not adherent, your viral load goes up, and what you're ending up doing is creating more reservoir sites. So this is the key. And so we don't want, so I think until we get a lot of this sort of addressed, these barriers, moving forward is going to be, it will be difficult. Here we gotta click on this thing. Oh, so this is sort of the pivotal thing, latency. So this is what is sort of the hallmark of what makes HIV much, much different than a lot of other viral infections. So there is no latency, there is no reservoir site with COVID. All right, so that's you either you get it, you recover, or you die, but you don't have to worry about, I'm going to have this for the rest of my life, because there is no reservoir, there is no latency. This is not where the viral DNA gets incorporated into your DNA. So this is the definition of a sort of latency. You have persistent viral reservoir that harbors integrated. It went from the cytoplasm of the cell into your DNA and your chromosomes. And now you have replication competent provirus. That means at some point in time, this virus has the capacity to start replicating itself. And it does that with the within the host cellular DNA. So this is a way to take this virus and sort of immortalize it, in the sense that that virus is going to stay alive as long as you're staying alive. The idea then is that it's now part of you. Now, when you look at where these reservoir sites are, the majority of these reservoir sites are in CD4 cells, T helper cells, CD4 memory cells. They're all got the same name. And if you're going to a doctor and you're HIV positive, they're going to talk to you about what's your viral load, how much virus can they measure, and what's your CD4 count. How many CD4 cells? People that are not infected with HIV have between 500 and 1,200. So the goal is to try and get your CD4 cells back into that normal range. And a lot of patients, the longer you stand adherent to your antiviral medications, you'll get back up. The problem here is the fact that every time you go off of your medicines and you have some replication of virus, other cells get infected, and you have these increase the size of your reservoir. All of these cells that are listed here, resting memory CD4 cells, that represents probably 70 to 80% of the reservoir. So these are cells that are CD4 cells, T helper cells that have been infected, and the virus just stays there. It's not doing anything. And those cells that are doing exactly what it sounds like, they're resting. Like what we do on a Saturday afternoon when you're my age, 70 plus years, you take a nap, you rest, you know. And so the cells aren't active, they're not replicating, they're not doing anything, they're just sort of there. And all these other cells that are there, myeloid cells, monocytes, macrophages, dendritic cells, follicular dendritic cells, and all the other ones that are there, these are cells that do not actively replicate. And so they're just part of the immune system. Now, what does turn them on, especially the one at bullet point B, myeloid monocytes and macrophages, those get turned on with other infections. So if you get pneumonia, your monocytes and macrophages are probably going to be stimulated, and those cells will start to replicate. And when they replicate, they have now allowing HIV to also replicate. And so part of this whole idea then is that if you have cells that are dormant and you want to get rid of the virus, how do you flush the virus out? And so part of it has to do with that you have to then stimulate some of these cells. And we'll talk a little bit about this. Now, the other thing that makes, when you start thinking about, well, these are the reservoir sites, and what do all of these cells have in common? Well, what they all have in common, they have a receptor site that HIV can attach to and infect. But all of them have different functions, and they have different half-lives. They live longer than other ones. They're macrophages that live for 50 years. So part of the problem then is trying to flush out, how do I get rid of some of these cells? And that's sort of kind of one of the pivotal questions that arise with the whole concept of cure. Now, what we have out there then is sort of is that you may or may not be sort of aware of this, of these individuals or elite controllers. We have not talked about this enough, and part of it is because of the fact that we didn't really sort of appreciate and I think understand. So elite controllers by definition are HIV positive individuals who control viral replication without any antiviral therapy. And then they represent a modeler of a functional cure. By functional cure, I mean that you live with the virus, but the virus doesn't do anything particularly bad to hurt you. I would be willing to bet that probably 90+% of people in this room are infected with cytomegalovirus, CMV. Probably even a higher rate of you are infected with another virus, which is called Epstein-Barr virus. You harbor this virus, but this virus doesn't really do anything bad to you. Now, there is some questions about if your immune system falls below a certain level. Your immune system can't keep CMV in check. And that's part of the reason why if your T cells, if you're HIV infected and they go below 100, CMV can start to activate itself. It can cause a bad infection in the retina of your eye. It can also be a reason why patients that are transplant patients that have had a bone marrow transplant or a kidney transplant or a cardiac transplant may have CMV start to replicate itself, primarily in the GI tract. And these patients can get just a horrendous colitis. The Epstein-Barr virus, again, it's probably thought to have some role in the causation of certain types of lymphomas, but most people just do fine with this. So the idea then is that elite controllers have HIV, but they're not replicating the virus. And so that happens to a couple of things, is they don't have enough virus to be able to transmit. And the other thing is that they don't have enough virus to continue to damage or suppress their CD4 cells. And so we can refer this then as a functional cure. So when we're thinking about curing, can we turn patients that have somebody who is just tested positive with HIV, has been put on medicines very quickly, they're been remained undetectable for 2-3 years. Can we then think about, is that a possibility? How could we turn that person into an elite controller so that they could stop their medicines and continue to do just fine, and that their immune system doesn't crater and there's no progression in their illness? And so that's what a functional cure, when we talk about functional cure, that's what we're sort of talking about. There's another thought that maybe you can actually eradicate HIV out of the body. So that's the idea of like sterilization. You've now eradicated the virus and you can't find it. Some of these elite controllers have now evolved into that state. And if you go on the internet, you'll find a reference to a couple of different patients in different parts of the world where this has actually happened. There's a woman who's been followed for about 30+ years in California who never been on medicine, continues to test positive, has positive antibodies to HIV, and has never been on any type of antiviral medication, and doing some very sophisticated tests and looking at all these other sort of sites, looking for not the presence of virus, but the presence of the provirus, the genetic material, and they can't find it. And so it's thought that this woman now is actually not just a functional cure, she's actually a real cure. And then I think a lot of people have heard the story of the Berlin patient and other patients that actually had their virus eradicated through a very radical process of having a bone marrow transplant where you get all the stuff to kill your immune system, and then their immune system came back and basically was somebody who donated bone marrow that had cells that were not able to become infected with HIV because they lacked a receptor site. And we'll talk about that as sort of the strategy with functional cure. Not bone marrow transplant, but whether or not you can sort of change the receptor on a CD4 cell. So, so this is where we're at. These are the cure strategies. So the strategies then it involve, first of all, early antiretroviral therapy and to limit the building of the reservoirs. So I think the most important, so if you take anything out of this conference or what I've made out of this discussion I'm having here, what is the important thing? The important thing is testing. We should test more and more and more, in the sense that what our goal is to find people very early on in their infection. You can find somebody, if somebody came to the clinic and they tested positive for HIV and they told you, oh yeah, you know, I had unprotected sex. Now they have positive antigen. Now, when you have the discussion with the patient, you tell them how sad you are and how you feel bad that they become HIV infected. But the other side of the coin is that you can tell them you may have won the lottery. Because we're going to get you on medicine, we're going to get you started on medication that's going to very quickly make you undetectable, and we're going to limit this idea of a reservoir. And so early initiation of antiretroviral therapy is going to be the key to cure. So we need to test more and more and more and more and more and find people very early on in their infection. And if you can do that, you can get exactly what it says here, reduce the size of the reservoir. Because if you can reduce the size of the reservoirs, then you're going to make it much, much easier to be able to do things that may occur next, which is to get rid of the virus. So right now, the strategies about this is something called shock and kill. So this is a concept where you're going to flush out the latent reservoirs. Well, how are you going to do that? Well, there are a series of different medications that what we know is that if you stimulate the immune system in such a way and make the immune system respond by creating certain types of proteins, which are called cytokines, you then can stimulate a lot of these different reservoir sites. They may be macrophages, monocytes, could be these sort of resting CD4 cells. And you're going to stimulate those cells, and they're going to release HIV. Now, if you're on medication and you get this stimulation and you release the HIV, as long as you're on medications, you don't reinfect new cells, because now you're inhibiting the whole replication process. It's sort of like the whole concept of PrEP. You have something on board that's going to prevent the replication of the virus. So we know that this happens all the time. I see patients all the time that will come into clinic. They have not had a viral load for maybe 3, 4, 5 years. They come into clinic, and then just on that particular day, they're coming in for routine testing, and they may also tell you, you know, I think I may have done something wrong. I got this kind of rash, and this rash, you know, it looks just like the rash I had before when I had syphilis. Okay, so you are part of the labs that day. You're going to check their viral load, their T cells. You're going to check a screening test for syphilis called an RPR. And I can't tell you how many times we've seen that in those individuals, their RPR is positive, and what you see is this very low level of virus. 200 copies, 300 copies. And is it real or not real? You treat the patient's syphilis, you get them back into the clinic like 5 weeks later, 6 weeks later, you check their syphilis titer, it's going down, and at the same time, the viral load is undetectable. What happened is syphilis stimulated their immune system in such a way to make these reservoir sites, these hiding sites, replicate, and then they started to release HIV. So what we know is that if you can give certain types of medications then to stimulate certain cell lines, it may be that you can flush the virus out, and then as long as they're on medicine, you're not going to reinfect any new cells. So this idea of shock and kill, flush and destroy, that is sort of an idea. What needs to be worked out, and they've looked at this as mathematical models, how many rounds of this would you have to do to be able to eradicate virus? A lot. Probably over a couple of, many months, or maybe a couple of years. And so the things that have to be questioned and answered is, how safe would that be to continue to try to stimulate the immune system in such a way to get released virus? Number D says, make cells resistant to HIV. So we know that there are people out there in this world, and there's a high concentration, well, not a high concentration, about maybe 3 or 4% of the population of Scandinavia have a genetic deletion that does not allow them to have a receptor site that HIV has to attach to be able to infect a cell. It's called delta 38 deletion. And what you know, the people that do not have this, that have this deletion, they're sort of resistant to HIV. So the story about the Berlin patient, the guy who got a bone marrow transplant, his donor was from Scandinavia, and he had this deletion. So that now, even though the Berlin patient had HIV for 25 years, they got rid of all of his CD4 cells. They eliminated all the reservoir cells, theoretically. And then what they found is that they couldn't find the virus anymore. And then they also found out that the person that gave them the bone marrow had this deletion. And so kind of all the things just kind of fell into line. So is it possible that when to do manipulation of the HIV receptor site, is there a way to do gene therapy to turn something on and turn something off? And the answer to that is yes. So that there's a way then to manipulate CD4 cells and to turn off a receptor site. So some of that is sort of what we call gene therapy. There's something called CAR T cells, which stands for chimeric antigen receptor, where you change the configuration of the receptor site in such a way that HIV cannot recognize it and attach to it. And then you can redesign sort of T cells. And all of this is sort of involved in sort of how you can stop the virus from causing any more havoc by not getting into it. Now, if you think Biktarvy is expensive, you can just imagine how expensive this is going to be, where you take somebody's T cells, manipulate them, and then reinfuse them. And then the last one may be the most sort of doable. And this is sort of deplete infected cells. So now, how do you get rid of the reservoir sites? And so this has a lot of also crossover to why does your immune system not recognize cancer at times? Every day of your life, you have cells that are mutating, and you have little cancer cells being created every day. But why does not everybody in this room have cancer? It has to do with your immune system identifies these cells, and these is your CD8 cells and your natural killer cells. They recognize these tumors and they clear them. Why doesn't this happen with HIV? Why is your immune system not identifying these latently infected cells and getting rid of them? And part of the strategy or the thought process is that there is some protective camouflage covering that your immune system is not able to see through. It's not able to identify those cells that should not be there and get rid of them. And so they're just as you hearing all of these things about the advertisement on TV, which is immune-based therapy. It's basically trying to allow the immune system to recognize something that it's not seeing. And these are called PD-1 inhibitors, or programmed death 1 inhibitors. So the idea, if you use these inhibitors, does it remove this sort of, this overexpression of PD-1 that is maybe on these chronically infected cells, and the immune system is just not seeing them, not able to recognize them? But if you did that, then what you may be able to do is clear the virus. And there are a handful of patients. These are patients that had melanoma and HIV. And what's interesting thing about them is that the standard treatment right now for a good part of melanoma patients, and especially metastatic melanoma, is this immune-based therapy. And so when this has been tried in HIV patients, not only did their melanoma go away, but actually their viral loads got better and their CD4 cells started to come up. So it's not, so that's where we're at. So right now, we're sort of trying to put the pieces of the puzzle all together. I think the main message for people right now would be is if you have HIV, find it as soon as possible. If you have any doubt if you've been exposure, get tested. If you think you're at risk for HIV, get into a clinic and get on PrEP. Because what that's going to then allow you is to have access to medical care. And for somebody at this age of their medical career, working at the Kind Clinic has been sort of a blessing to me because of the fact nobody gets turned away. Nobody, where's you got an insurance card? You got a copay? None of that stuff. You need care, you get care. You have no insurance, we figure out a way how to get you PrEP. We get a way to get you tested. So I can't overstate the fact, testing, find patients early, get them rapidly on medications, and then hopefully, in the next few years, we can get them lined up for one of these strategies that will cure their infection. So I think that this is a good time to be hopeful, because I think we're really on the dawn of a new era in the regard of HIV care and treatment. And this whole idea, I think we have really kept hope alive for these last 30 plus years. And all of this stuff now is coming to fruition. Which I could say the same thing about COVID. There's no light at the end of the tunnel, but there is a light at the end of this tunnel. Thank you very much.
We have a couple minutes. Does anybody have any questions for Dr. Wright? I'm coming right to you.
Yes, ma'am.
I'm not sure if you're familiar with the individual in Argentina that was naturally cured of HIV. I'm not sure how that possibly happened, or if you're familiar.
Yeah, so here's what the idea of what we're thinking is happened. So this is a person who became infected with HIV, and we're not quite sure of whether or not, was there something unique about the virus that infected her? Does it have the ability to replicate itself? Does it have the ability? So there may have been something there. But the thing is that from that person, they were able to kind of follow this person over a long period of time. And what they were able to do is that when we talk about these reservoir sites, they were able to find evidence of the virus in those reservoir sites. And this is what we call a provirus. So those cells have the ability to eventually start to make HIV, but they weren't making. So the question is why? And this over been a 20 some odd year period of time, they followed this lady, her immune system came in intact. And what has happened in my mind is that her immune system has identified those reservoirs sites. He's cleared and killed off all of those cells. Now they're gone. It's because now, like about a year or so ago, they did an exhaustive search. They looked at over 20 billion cells. They cannot find any evidence of provirus. So this woman doesn't have it anymore. And so that's kind of amazing. That's probably a 1 in a gazillion, but it does tell us, it gives us an insight in that what is potentially possible. So I think for most of the people that have HIV and they're looking at this as an issue, they would like to just have the functional cure. Can I just have be off of medicine and just have a little bit of virus and I don't get sick? Because what patients want now is, we get, and what's hopeful about it is the fact I get, what about the injection? What about the shot? Can I get the shot once a month? Yeah, that's a viable treatment. And a year from now, we're going to be talking about patients that are getting a shot once every 4 months and controlling their HIV. But for a lot of patients, it's like, what if I never had to take it? And that's the other thing. And if you can cure the patient, you probably change all the other dynamics of that.
Anyone else with other questions?
Anything else?
This is your international expert right here.
Yes, in the back.
Coming with Mike, since we've got people who are on the line, so they'll be able to hear the question as well.
Thank you so much for being here. Really appreciate the education. With the advancing nature of the technology of HIV drugs, things like Capella, Cabenuva, is it wise for those HIV positive patients to switch regimens even though they may not have failed treatment? Is it bad for them to switch regimens?
Yeah, I think this is a discussion we've had for a long period of time. So like back in 1996, you had patients that were on a handful of medicines and doing fine. They hadn't had a viral load for 5 years. Is it safe for me to go to that 1 pill once a day regimen, the triplet? Yeah, and then so if you don't have resistance to the components of your regimen, you're probably going to do just fine. I think that it's a discussion you should have with your physician. The physician will kind of tell you the pros and cons of this. I do think this discussion will be becoming much more relative in the future. There are a couple of game-changing drugs coming. One's from Gilead. It's called lenacapavir, which is a capsid inhibitor. It's a new novel approach to destroy the ability of HIV to build itself back, and plus there will be a brand new drug. It's a non-nucleoside reverse transcriptase inhibitor with a new function that we've never seen before called a translocation inhibitor. It's made by Merck. It's called islatravir, and this will be another game-changing drug. Probably if you look in the papers or follow the internet, Google, the two companies, Merck and Gilead, made a collaboration. They're going to make an injectable form of this, and you'll see this in the future, and this may allow patients to get a shot of a medicine maybe once every 3 to 4 months. And then it also opens the technology of could you just get an implant, and you get something put into your arm that lasts for a whole year or for 6 months, and then you put it in on the other side. So yeah, that's where we're moving. More potent, safer, more durable. Ultimately, the goal is get rid of the virus. All right, bye.